Welcome back, guys. We will be discussing today PCOS ESHRE guidelines. These guidelines were released by ASRM ESHRE as international evidence-based guidelines for assessment and management of polycystic ovarian syndrome in 2023. So today we will discuss about these. Prevalence of PCOS. So the prevalence of PCOS is highly dependent on the ethnicity and the region where the patient belongs. The prevalence is very high. It is around 10 to 13% when the Rotterdam criteria is used. What is biochemical hyperandrogenism? Biochemical hyperandrogenism means when the testosterone levels, the androgen levels in the blood are high. So what are the androgens which we need to check for biochemical hyperandrogenism? It is the total and free testosterone which is required to assess the biochemical hyperandrogenism. If testosterone or free testosterone is not elevated, then androstenedione and dehydroepiandrosterone sulfate needs to be measured. And what is the accurate method to measure these tests? That is the mass spectrometry. So it is very difficult to reliably assess for biochemical hyperandrogenism in women on combined oral contraceptive pills. Why? Because COCPs, they increase sex hormone binding globulin levels. So that's why we must withdraw the pill for minimum of 3 months if we actually want to assess the biochemical hyperandrogenism. There is no role of repeated androgen measurement, and other causes of hyperandrogenemia must be ruled out before making a diagnosis of PCOS. We all know the hyperandrogenemia can be because of the ovarian and adrenal neoplastic growths, congenital adrenal hyperplasia, Cushing syndrome, ovarian hypertrichosis, and there can be iatrogenic causes, as well as there can be the reasons like medical causes, like medicines. Patient might be taking some medications which might be responsible for decrease in sex hormone binding globulin and hence the elevation of the biochemical levels of the testosterone or other androgens. So that's why we need to rule out all these things. Coming on to clinical hyperandrogenism, the scale used for the visual assessment of hirsutism is the modified Ferriman-Galway scale, and for female pattern hair loss is the Ludwig or Oslin visual scales. And for acne, there is no, as of now, there is no scale which is used to assess the acne. Only terminal hair we need to measure, not the vellus hair. And any new onset severe or worsening hyperandrogenemia, the androgen secreting tumors and ovarian hypertrichosis must be ruled out. Next is the ultrasound and the polycystic ovarian morphology. Follicle number per ovary should be considered as most effective ultrasound marker. So there are many ultrasound markers. They are like follicle number per ovary, follicle number per section, or ovarian volume. So there are many markers, but what is the most important is the follicle number per ovary. And follicle number per ovary more than or equal to 20 in at least one ovary should be considered the threshold for PCOM in adults. Ovarian volume more than or equal to 10 ml or follicle number per section more than or equal to 10 in at least one ovary can be taken as a threshold for PCOM if we are using the older machines. There is no definitive criteria in adolescence, and transvaginal approach must be used. If we are using the transabdominal ultrasound, then ovarian volume is to be taken, and anything more than or equal to 10 ml in either ovary is suggestive of PCOS. So there is no definitive criteria to define polycystic ovarian morphology on ultrasound in adolescents. So it is not recommended in adolescents. Why it is not recommended? The data is inadequate in young women with a gynecological age of less than 8 years. Other reasons are peak ovarian maturity has not reached by that age and AMH levels are still rising. There are anyways high incidence of multifollicular ovaries even in normal girls. So that's why this all will lead to overdiagnosis of PCOS in adolescents. So that's why ultrasound criteria is not used. Role of AMH in diagnosis of PCOS. AMH is not taken singly for PCOS diagnosis, so it should not be used as a single test. And it should not be used in adolescents also. So there are a few factors which influence AMH. AMH peaks between 20 to 25 years and it is lower in those with higher BMI. And continuous OCP use will decrease the serum AMH levels. Menopause life stage. An additional recommendation was added here, like in 2018, this recommendation was not there. So the 2018 PCOS guidelines have been updated in 2023. So what is added is that even at menopause, still these women are at increased cardiovascular risk. Any woman with PCOS has increased cardiovascular risk even when she reaches menopause. So the diagnosis of PCOS is considered lifelong. And both clinical and biochemical hyperandrogenism persist in the postmenopausal status for women with PCOS. So in case there is a past diagnosis of PCOS, so that woman always runs a high risk of cardiovascular diseases. So they should be considered as a high risk, and every time they come, the blood pressure measurement, the lipid profile, all these tests, just like in any PCOS women are done, they should be done in these women too. So again, the same thing, lipid profile at diagnosis and blood pressure measured annually. Impaired glucose tolerance test in type 2 diabetes. PCOS women are at risk of impaired glucose tolerance test. It is usually seen in around 35% of the women with PCOS, and type 2 diabetes is usually seen in approximately 7 to 10% of the women with PCOS. So it is quite common, so that's why we need to rule out these two in women with PCOS. So what is the appropriate method to rule out? So it is the 75 gram OGTT test. That is the most accurate method to assess the glycemic status in PCOS regardless of BMI. HbA1c is not a very good test to assess the glycemic status in PCOS women. Coming on to obstructive sleep apnea. So women with PCOS have high prevalence of obstructive sleep apnea independent of BMI. Endometrial hyperplasia and cancer. PCOS women are at higher risk of developing endometrial hyperplasia because the baseline estrogen is always high and there is no progesterone to support the endometrium. But because the overall chance of developing the endometrial cancer is low, therefore routine screening is not recommended. The preventive strategies include weight reduction, cycle regulation, and regular progesterone therapy. Risk in relative. The fathers and brothers of women with PCOS may have increased prevalence of metabolic syndrome, type 2 diabetes, and hypertension. But the similar risk is not seen in the female first degree relatives. Role of combined oral contraceptive pills. COCPs are recommended in reproductive age adults with PCOS for management of hirsutism or irregular menstrual cycle as the first pharmacological agents. They can be considered in adolescents too, who presents with hirsutism and irregular menstrual cycle. There is no clinical advantage of using high-dose ethinyl estradiol versus low-dose ethinyl estradiol. The 35 microgram ethinyl estradiol plus cyproterone acetate preparations should be considered as second line. Progesterone-only contraceptives may be considered for endometrial protection, acknowledging that evidence in women with PCOS is limited. The absolute contraindications must be kept into mind while prescribing the COCPs. The current evidence suggests that COCPs containing levonorgestrel, norethisterone, and norgestimate, which are first, second, and third generation progesterones, are associated with lower risk of venous thromboembolism. Because we have to give these medications for long. So the safer medications which have lower risk of venous thromboembolism, which are first, second, and third generation progesterones, must be given. Combined oral contraceptives with 35 microgram ethinyl estradiol and cyproterone acetate should not be used as first line because they are associated with higher risk of venous thrombosis. Role of metformin. Metformin alone should be considered in adults with PCOS and a BMI more than 25 kg per meter square. But they can be considered in adolescents as well as in the women with lower BMIs. The most important side effect with metformin are the gastrointestinal side effects like nausea, vomiting, diarrhea, but they are usually self-limiting. The maximum daily dose of metformin is 2.5 gram in adults, 2 gram in adolescents. And metformin might be associated with lower vitamin B12 levels, so they should be assessed timely. Anti-obesity pharmacological agents. There are anti-obesity medications which are available like liraglutide, semaglutide, and the glucagon-like peptides and orlistat, which can be considered for weight reduction. But whenever we are giving GLP-1 receptor agonist, effective contraception is must. Role of anti-androgen pharmacological agents. If there is suboptimal response after a minimum of 6 months of COCPs, we cannot add anti-androgens without giving 6 months of COCP trial. Once the 6 months have been given, still if there is no improvement in hirsutism, then anti-androgens can be supplemented. But whenever we are giving anti-androgen, the proper contraception must be given because there is a risk of incomplete development of external genital structures of male fetus. The anti-androgens like finasteride and flutamide are associated with liver toxicity, so this thing must be kept in consideration. Pregnancy outcomes. So the women with PCOS have higher risk pregnancies because they run the risk of higher gestational weight gain, miscarriage, gestational diabetes, hypertension, intrauterine growth restriction. It is not macrosomia, it is intrauterine growth restriction, which is more common in PCOS women, preterm delivery and cesarean section. So women with PCOS should be considered as not having an increased risk of large for gestational age babies, macrosomia and instrumental delivery. Okay, so this point is important because we always think that the PCOS women have higher risk of macrosomic baby, but it is otherwise. They are at higher risk of small babies. Coming on to infertility. So first line pharmacological agent for ovulation induction is letrozole. And there is no evidence for increased teratogenicity compared to other ovulation induction agents. Role of clomiphene versus letrozole. Letrozole should be used rather than clomiphene in women with PCOS with anovulatory infertility. There is no difference in fetal abnormality rates between letrozole and clomiphene. Role of gonadotropins. Either gonadotropins or laparoscopic ovarian surgery can be used. Gonadotropins are associated with higher multiple pregnancy rates. The recent WHO 2025 guidelines give weightage to gonadotropins over laparoscopic ovarian drilling as a second line management for PCOS. Then the cycle cancellation, if there is more than total of 2 follicle greater than 14 mm, then the cycle cancellation should be considered because this increases the risk of multiple pregnancy. Laparoscopic ovarian surgery, it is second line therapy when in case of clomiphene citrate resistance. Role of in vitro fertilization and in vitro maturation. If the first and second line ovulation induction therapies have failed, and because the PCOS women run high risk of preterm birth and pregnancy complications like hypertension, small baby, so elective single embryo transfer is always preferred. There is always a risk of ovarian hyperstimulation syndrome, so these things must be kept into consideration. Gonadotropin releasing hormone protocol. which one should be used? It is the antagonist protocol, as we have already discussed in our previous videos on controlled ovarian hyperstimulation guidelines. And why antagonist protocol we should use? Because it enables the use of agonist trigger without compromising the cumulative live birth rate, and it significantly reduces the ovarian hyperstimulation syndrome. Trigger type. What is the trigger type? GnRH agonist is usually in the form of either triptorelin 0.1 to 0.4 mg or leupride 1 mg to 2 mg, followed by freezol is the trigger type which should be used. What is the choice of follicle stimulating hormone? Either urinary or recombinant products we can use. Any role of adjunct metformin? Only in cycles where GnRH agonist long protocol is being followed, there is role of metformin. Otherwise, there is no role of metformin if we are using the GnRH antagonist cycles. Role of in vitro maturation. IVM can be considered in women with prior severe ovarian hyperstimulation syndrome and where the risk of severe ovarian hyperstimulation is deemed unacceptably high. Although the IVM ICSI is less effective than standard IVM ICSI, but still it is one of the methods which can be used in patients with very high risk of OHSS. So thank you guys. We will be coming up with many more videos. So thank you for your patient listening.